Good afternoon and dear audience. I, Ananya Hota, is going to present on the topic of anterior uveitis in young patient. No financial support or conflict of interest is present. My patient is a 38 years old male from Puri. He's a businessman by occupation. He's Hindu by religion with chief complaint of redness in his left eye since 5 days, pain and discomfort of vision since 3 days, and photophobia since 1 day. In history of presenting illness, the patient was apparently alright 1 year back. To start with, he developed redness, pain and diminution of vision and photophobia in left eye, for which medication was taken. Similar episodes happened 6 months back. Now he presented with complaint of redness since 5 days, pain and diminution of vision since 3 days, and photophobia since 1 day in left eye. In past history, similar episode 2 times in past year. Arthritis is present since 4 years. No history of diabetes mellitus, hypertension, asthma. Family history is not significant. In personal history, food habits is a good diet. He has a good appetite, normal sleep cycle, normal bowel and bladder habits. Not a known alcoholic and smoker. The patient was conscious, cooperative and well oriented to time, place and person. Average built and well nourished. His BP was 130 by 80. Pulse rate was 82. And respiratory rate was 18 cycle per minute. Temperature was 98 degree Fahrenheit. No icterus, clubbing, cyanosis, lymphadenopathy, pedal edema or pallid seen. Systemic examination, the CVS S1 S2 heard. Respiratory system, bilateral vestibular breath sounds were heard. CNS, no focal neurological deficits. And in per abdomen, soft, non-tender, no organomegaly was seen. Coming to the ocular examination, head posture was erect, facial symmetry was present, ocular position was normal and alignment was orthophoric. In visual acuity, in his left eye was 6 by 36, by pinhole improvement was 6 by 24, near vision was N10 and color vision was normal, ocular mobility was full and free, IOP was 11 mmHg. In the slit lamp examination, in the left eye, orbital margin was normal. In eyelids, mild swelling was present. Lacrimal apparatus, Roplas was negative. In conjunctiva, circumcorneal congestion, no follicle discharge and new growth was seen. Sclera was normal. Cornea was lustreless, small, dirty, white, granular keratic precipitates. In corneal endothelium, arranged in a triangular fashion, were seen in the center and inferior part of the cornea. In anterior chamber, aqueous flare +3 and aqueous cell +4. Hypopyon was present, iris was hazy, pupil was constricted, sluggishly reacting to light, lens was normal. In the right eye, everything was within normal limits. Coming to the fundus examination, in left eye, inadequate dilation, fistuled pupil was seen. Segmental posterior synechia at 11, 1, 6 and 7 o'clock position was seen. Fibrin membrane was present on the lens, vitreous haze present, posterior segment could not be visualized. Right eye was within normal limit. Coming to the findings, here we can see in the left eye fistuled pupil and segmental posterior synechia in the left eye is seen. In investigation, B scan was echo-free and all other investigations were not reactive, but HLA-B27 was positive. Hence, it's a case of acute iridocyclitis. Differential diagnosis can be acute conjunctivitis and acute congestive glaucoma. Coming to the treatment, we can give topical steroids, cycloplegics, antibiotic topical drop, symptomatic treatment, and systemic steroids were given if required, and he was asked to go for a rheumatologist consultation. Thank you.
In case of an uveitis, you need to take an history which you call uveitis oriented history, where you look for history of joint pain, low backache, mouth or genital ulcer. That systemic history would be important. But there is no point on taking the history of the cardiovascular system and with the auscultation findings and all. That is not really required. And ophthalmic history is that whether there is a pain, redness, photophobia, whether there is a dimness of vision, there is a flotus, this should be taken. And investigations, you should focus on the investigations like according to the clinical findings, tailored focused laboratory investigations is required. In this case, HLA-B27 and collagen workup would be good, more than enough to do the laboratory investigations. And you do not need a detailed evaluations for this. And the treatment on that, there is no role of antibiotics in such cases. the topical steroid with mediatic psychoplegic agents would be there enough for the treatment.
Whenever you are seeing a patient of hypopia and uveitis, you will have to rule out. If a patient is young, you will have to rule out HLA-B27 associated spondyloarthropathies, or if a patient is young, you will have to rule out Basids, because Basids is presenting with hypopian, but that is seen only nowadays in 20% cases because of the judicious use of steroids. And since your patient was having recurrences, so you will have to take care of these patients with a regular follow-up, and if your patient is having frequent recurrences, then it is always advisable to switch over to immunosuppressive agents, particularly the methotrexate if a patient is having this type of arthritis. I think that will help not only in relieving the arthritic element, but also help in getting the complete remission of the inflammation, because ultimately all these patients who are having this HLA-B27 type of uveitis, you will have to achieve complete remission either by the means of immunosuppressive agents or the biologicals. So it was a good case. Thank you.